All right, well, we'll go ahead and get started. And thank you, everyone, for joining again this week. And as always, I want to go through. Tonight we don't have a CE presentation, but I do want to continue to go through some of the stats just to update you with what's going on around the state and to address a couple of issues of information, and then we'll open up the floor to everyone. So hang on one second here. All right. Thank you again for everyone, like I said, for joining tonight's meeting. As we get through to the town hall portion here in a couple of minutes, just remember, as we'll go through, everyone please keep your microphones muted if at all possible. And if you do want to raise your hand, hit the participant button and raise your hand, and or use the chat function, and we'll be able to help process your questions and engage in our discussion. So this week we've seen a significant increase in COVID-19 cases. Around the world, we are now at 4.3 million cases. In the United States, we are about one-third, almost 1.4 million cases. And we're just at under 300,000 deaths globally. Whenever they start looking at recovered, the numbers are still pretty low on people that are considered fully recovered. I think a lot of different countries are taking a different definition of what they're considering recovered. Some are doing it after 14 days. Some are going well beyond up to 28 days. Illinois is continuing to progress in its infection rate, despite what some elements of our media and more of social media may be thinking. We're just under 85,000 cases total for the state. As of today, we've increased the number of counties. Now 98 of the 102 counties do have COVID cases. So I know a lot of, being down from the southern part of the state, I know there's been a lot of pressure of reopening, and that's where some of the new cases are starting to pop up. So, as we know, Madison County and Adams County are trying to experiment with going back to being fully open. I know in Madison County, a lot of businesses are still respecting the governor's plan and executive orders. So we'll see how some of our communities, as they continue to have challenges with the current government plan, and seeing how that goes over the coming days. Unfortunately, we've had 37, almost 3,800 deaths now in Illinois. We've had our highest deaths over the last 24 hours for any given day of 192. And as you can see here, you can look at the different counties, and you can kind of see, that we have a significant amount of cases per 100,000. And if you start taking a look at how that is reflected throughout the state, we're still, the Metro East component is starting to grow, in addition to what's going on here in Sangamon County. And of course, as we've talked about with Sangamon County before, as an example, we're over 200 cases, but over a third of them is from one nursing home. The social distancing forecasting, or reporting, I guess, not forecasting, but reporting based on our cell phone movement is Illinois last week, as we showed you, was at a C-. We're now at a solid F. And most of the country is at a D right now. So it is, I think, as we've talked about, as the length of these stay-at-home orders extend, and I think just as the weather gets nicer and people are just wanting to get out And I think that may have some ramifications as we continue to proceed. But I think people just need to keep a smart mindset. And at least if everyone can try to, maintain the mask policies as we're out and about, that will definitely help with decreasing transmission. One of the things I did want to shift over and review that came out today, the General Assembly has announced that they are going to go back into session next week. And what we're hearing, it says beginning on May 20th, so that's next Wednesday. So next Wednesday, Thursday, and if needed, Friday. The Senate and the House have issued a joint proclamation, and they're actually calling this a special session. And the reason they're calling it a special session is because the House will not be meeting at the Capitol. To maintain social distancing, the House has arranged with the Bank of Springfield Convention Center or the Prairie Convention Center, depending what names you know it by, and they will be using the Convention Center as the House chambers for the special session next week. It is undetermined at this point if the Senate will be using the Senate chambers or if they may be spreading out to use the House chambers for an additional space. We'll see how that goes here in the next week. But as you see here, the special session will only be dealing with 7 topic areas. So, of course, I zoom in and it blanks out. There we go. Anything related to COVID-19 pandemic, the state budget, which is what we've been talking about that they have to deal with before May 31st. They're wanting to review some economic recovery or infrastructure projects and other fundings. Anything having to do with constitutional amendments in relation to the Constitutional Amendment Act, excuse me, and laws or authority scheduled to be repealed prior to June 1st of next year. And that's different from what we were hearing before. As you remember, we were talking about that each department was being asked to provide needs that had to be, anything that had to be addressed before January 1 of 2021. This is going forward at least until the end of the next General Assembly. So the General Assembly is trying to be a little forward thinking in case issues continue to progress. Any issues revolving the 2020 general election and the State Board of Elections. As you know, the governor has continued to press that he is hoping that Illinois can move to a 100% mail ballot situation for this upcoming presidential election. And then the hospital assessment program. So the 2 leaders are really wanting to try to keep it within these topic areas and these topic areas only. We'll see how this progresses. There's still a lot of pressure from the General Assembly from meeting, but I also know that there's still a lot of hesitation amongst members of the General Assembly for meeting. So at least at this point, we figure they're going to come in, they're going to do business, and then they're going to get out of Dodge. And that may be it until veto session, if we have a veto session. Since there hasn't been a lot of action in this General Assembly, there really isn't a lot of bills that would be dealt with in a veto session. So we may not have one later this year. But they could come back in the summer. And so I don't know, there's a lot of things that are going on that they could decide, but at least right now we know this is what they're wanting to address. And with that, I do want to go ahead and open it up for discussion with everyone. That's really a lot of the major information that we had to share with you this week. We've been working with trying to continue work on COVID testing to figure out how payments are going to work. I know Starla's been working a lot back and forth with some conversations with the national organizations on this. There's some high-level conversations that are going to be happening probably between today and through the end of the week and the very first part of next week in trying to help determine on a federal level. And we are going to be working on some, I'm going to say, padded guidance of trying to make sure that HFS and Department of Insurance recognize that pharmacists are providers. Since we're already, everything should already be, nothing should need to be waived. It just needs to be letters recognizing the fact. So if we have to look at anything legislatively, I hesitate even trying to put anything into any of these packages that are going to be moving next week. But we'll see where we go as we go forward in the coming days. Steve saying, does Illinois allow pharmacists or pharmacy interns to do COVID testing on patients? Pharmacists can. At this time, student pharmacists and may not. And that goes for graduate pharmacists as well. Right now, you have to be a licensed registered pharmacist to be able to administer and authorize and perform any of the COVID-related testing. And again, you have to be not just any pharmacy can do it. You do have to be at least a CLIA waived laboratory. And we've talked about that, and we're going to be sending out some guidance, some basic guidance documentation here later this week about trying to help get you through the very first parts of this. And also, if you are a pharmacist working in a health system that may already have a program set up, or if you are working directly under IPhA or the Department of Public Health. And Starlin's added that IPHA recently launched a new and important call to action campaign, and we need your help, so please contact Congress immediately and tell your federally elected officials to allow pharmacists to test Medicare patients for COVID and influenza. And they want to try to get 10,000 on the letter goal. And so that was that this afternoon, Starlin, that came out? I can unmute you here if I can find you.
Yes, that came out at the end of the board meeting. I got a email from Mary Ryan, and I'm cutting and pasting. I'm going to send you the links so you can post it onto the.
So you can get a farm flash out.
Or get a farm flash out. Yes.
Okay.
They want to link them so that we have something after COVID. There's not any reason if we're doing COVID testing that we can't do flu in more than just Texas and Michigan. What are the states that we can do flu tests? There's only two.
There's a couple different states that can do it, but some have allowed it under their executive orders. So. And
get paid for it.
And get paid for it. Yes, absolutely. That's the big point, and that's why we've been really pushing to make sure that we don't release the hounds too early.
So tomorrow afternoon is at 4 o'clock is a CMS call with the office people, and then Friday at 12:30 till 2 o'clock is a CMS call to the people in the front lines, and that's where I've been calling in, and other people. I'm not the only one, but we've all been signing up and calling in and listening to what Administrator Verma's people are saying, and then they let some people call. Tomorrow, the American Diabetes Care and Education Specialists, we're all supposed to dial in so that at least one of us can ask that question as to why pharmacists and nurses aren't included in the DSMT delivery of telehealth. But I also know we get to ask 3 questions on Monday in the face-to-face or socially distanced face-to-face meeting with ASHP, NCPA, and IPHA are meeting with CMS, and they're asking about the diabetes centers and pharmacists being able to bill there, why they didn't clarify on what was it that you said, Garth? Clarify on our billing for testing and for antigen and antibody and for why we have to bill as a laboratory and why we can't just be given
bill as providers, because we're still billing as buildings and not billing as individual people.
Right, but even the DSMT is billing as a building, and then the other ask, there's another clarification point so they get 3 questions. Each association grabbed one. So that's what's going on Monday, but I'm dialing in tomorrow, and I'll put all the dial information onto an email for Garth. So if Jenny, Jenny Roselli, did you get the ADCS? Anyway, I'll send the information to Garth and he can post it.
Sorry.
Okay, sounds good.
Thing from ADCS?
So ADCS posted in their chat about calling on, so on Tuesdays, every Tuesday and Thursday, they've been having these COVID calls. They last about an hour and they take about 2 people. So the theory is on Thursday for all the diabetes pharmacist educators to get on so that somebody can get their question answered, and we're gonna all ask the same question to recognize pharmacists as providers for diabetes education programs. We weren't included in the telehealth expansion as separate entities. We can through a doctor and we can through a hospital, but we can't if we have, Missouri has a lot of accredited DSMT programs. And so they can provide the DSMT, but they didn't include that relaxation in the telehealth and telephonic process. We can through a doctor or through a hospital, or if you're at a FQHC, but all the standalones didn't get addressed again. Anyway.
Thank you, Starla, for the update. Let's see here. Yeah, Abby's saying that it sounds like a great opportunity for pharmacists to get involved. Abby, I would say this is a pinnacle moment for pharmacists to get involved.
Yep.
This is huge. This is where, as I said at our board of directors meeting for the association today, this is a time where we have to make sure that pharmacists are actively involved with this, but doing it appropriately, because this is an easy way for some bad actors to go out there and try to rush this, and then we don't get this, and it gets pulled away, and we're never going to have it again. So we have to make sure that we do this appropriately, and we do this without too much delay for patients, and we have to do it very safely. That's where I've started to ask back out to some wholesalers. We found out from one wholesaler yesterday that they may not be dealing or offering or providing access to any of the COVID tests. They have questions about some of the manufacturers, so they're just not going to get into the game. And so we do know that other manufacturers are going in head first, trying to provide all avenues of support and access to the tests. But we also are trying to push the going, well, with tests come PPE, and you have to have both. You can't have one or the other. You have to have both. Byron has asked, has there been any discussion on the CAP funds in the budget? I did have a discussion with our lobbyist today, Brian Daly, and asked with double checking and circling the wagons to make sure that the CAP funds will be included in next year's budget. We have not heard back yet. I know that the CAP funds were planned to be in the budget for fiscal year 2021, but we will work to get confirmation on that from the budgeteers. I know that there's some concern also about CAP fund payments. That one, I've also asked to have a question brought forward from the comptroller about if if HFS does send additional invoices in, what type of status will they be given? We do know that right now with cap funds, or actually, just excuse me, with any of the comptrollers, because of the massive amount of COVID spending that the state has done, it has basically put an extended backlog on all payments of every type of invoice right now. The state's basically not, from my understanding, has slowed its pace on paying any other bills not related to COVID-19 at the moment. Abby, I'm going to unmute you. I didn't know if you had anything else to say besides your written comments. You're unmuted.
Thank you so much, Garth. Can you hear me okay?
Go for it.
Perfect. Yeah, I just wanted to follow up. I know you've been pretty active on a national level, and I was wondering if there are any lessons learned from other states that we can bring to the state of Illinois as we move forward toward expanding these responsibilities for our pharmacists.
In relationship to the testing?
Yes, exactly.
Basically, we're all in the same boat right now. No one is really, this is why, it's because it's such an important national aspect. Everyone is still trying to find out. We're all trying to crack the egg at the same time, and we're all looking at it from different levels and trying to make sure that we set this up appropriately nationwide. Good question. Gary Moreland, you are unmuted, or you should be here in a second. There you go.
I hate to be muted all the time. Thank you, Garth. How are you doing?
I'm all right. Yourself?
I'm all right. A couple questions. Byron's question about cap funds makes me wonder about, you know, the original cap funds was $10 million. We spent 5 or 6, and then never really knew how much was spent after that. And there was some concern that if we didn't have the right mix of people applying for that and spending it, that they might think, oh, they don't really need it. I wondered how that looks these days for this fiscal year, whether they're, I mean, with things change so dramatically, it's hard to know exactly what they paid out. And then go ahead, and then I'll add a second question, but go ahead, Garth.
That's a good question. I could easily see a reduction in the amount since at least last year, and at least from what I've seen for this year in payouts, it is not going to hit the $10 million, despite our ask to pharmacies to make sure that they're applying. But it could be interesting to see if, I hope we can keep the same amount just so that the program doesn't change. And that we can kind of encourage more pharmacies to continue to apply and try to make sure we can get all that money that's basically there for them, and they can log in and attest to it and get it to them. What's your second question?
Well, back to testing, and I don't want you to put on your soothsayer hat necessarily, but just, is it possible to even to lay out a fantasy or a best case scenario for let's say the next 90 days about how testing in retail pharmacies, let's say, could go? I mean, I hear some pretty successful testing programs that are done. For instance, so Memorial using Walgreens for their 24-hour turnaround. And so I know there's some recognition of the ability of pharmacies to do some things. And I know there's so many moving parts to this, both locally and nationally, that I know it's really hard. But just so I can wrap my head around a little bit, what could happen? I mean, I don't even know what's the most optimistic scenario, let's say, that would happen over the next 90 days, because I think we all think that the pervasive testing in every community is a key. I mean, I think they're talking about, let's go back and test everybody in some countries. There's 11 million people in South Korea. Let's just test everybody one time and see what happens. And obviously we're not going to do that, but what is anybody's most optimistic goal about this is what we could do if we mobilize pharmacies in not only nationally, but specifically in the state of Illinois to get this going, so that, let's say, in August or September, if there was even a remote possibility of sending kids back to school and getting programs going, can we say, yeah, we're ready to roll? Is that even possible?
Right now, we're not ready to roll. hopefully in the next 45 to 90 days we can be. And I think, and Starlin, feel free to jump in after with filling in any of my comments here, but I think right now on a national level, we're trying to find out, and we're trying to find out a lot of these questions of how to guarantee the best possible route of billing that guarantees that we're going to get paid and not put us into a merry-go-round of rejection. In addition, we're trying to find, because we're trying to establish provider level capabilities for pharmacists in this really puts up a monumental task of trying to get us all credentialed on healthcare insurance. And that puts up a possibility of, do we try to continue to find avenues to quickly get everybody credentialed so we can get them able to bill on the medical side? Or do we take an easy route and use an existing system, which would be going through the PBMs? And that, of course, scares the hell out of me, to be honest, on using the PBMs. And one of the aspects that has come up is that there are some emergency systems, emergency protocols that would put it through one PBM specifically. It's not CVS Health, and where that PBM would only have the ability to charge an administration fee, but that would require the federal government to set a solid reimbursement price to make sure that there wasn't any pricing manipulations. On us, that's too much of hitting the easy button, and I think there's a lot of pressure to hit the easy button right now. In addition,
there's two questions. I mean, you're right. It's easy. That would be the easy way to go, and it would get people going quicker. And that's what I'm not sure that in this case I even want to get involved if it's going to be something that's just no or complicated reimbursement. But at the same time, I want to help. I mean, I want to see Moreland and Devitt in these communities. I want to see them out there helping, but I can't do it. You know, nobody wants to do it if it's not going to make sense. And that's why, Starlin says we have to have testing or training, which makes sense. You have to have some kind of training, or if not certification, at least proof that you know what you're doing. That's fine. But can we move quick enough to do that in 60 days? That was my question.
I think we can. It's going to take a lot of hard work, and it's going to take a lot of pulling departments along. And I think that's what the nationals are trying to do with CMS right now. I think on a state level, one of the things I did bring up with Brian today when we had a discussion this afternoon was saying that we need to engage HFS on this question, because we're already considered providers under Illinois Medicaid. But we need to make sure that they understand that they're going to recognize us as providers on this type of a level. And I would encourage them, at least for the ease of use for Illinois Medicaid, would be for us to bill it under fee-for-service for everyone, regardless of their classification, if they're an MCO patient or if they're a fee-for-service patient. Just because the fee-for-service line, they could create the billing on the back end so that it would basically set us up for reimbursement as they would a physician or a nurse practitioner or a PA. And it's still using our existing system, at least for right now, and gives Medicaid time to get us set up so that we would be billing in the same fashion as everything else. That would be my proposal to them. And again, just trying to make it as quick as easy as possible. And so on the testing question, yes, we are working on testing. Our professional affairs committee has taken a look at, and we're still evaluating a couple programs that are out there. One that was offered to us and we looked at, it's a 30-minute program, and it was very inexpensive, but the problem is sometimes you pay for what you get, and it doesn't offer any type of skills assessment. And I think one thing that was quickly loud and clear out of our discussion from the Professional Affairs Committee was it has to have a skills assessment. This is something that you just can't watch a 15 to 30-minute webinar and go out and start sticking probes into people's nostrils and into the cavities without knowing how to do it appropriately. which means you have to do, and we can set up virtual skills assessments to do this. And to do it in a fashion that we did under the NACDS point of care program is you would have to do the nasopharyngeal collection on yourself, so you know how it feels, and then you do it on a partner, hopefully with different swabs. So we just want to make sure that pharmacists are doing this appropriately. Again, we want to make sure that we're setting this all up to show that, yes, we are competent enough to do this safely, effectively, repeatedly, and be able to offer this on an ongoing basis. So my goal, I was asked a lot of questions from the Chicago Tribune a couple of weeks ago about how many pharmacies that we want to be able to do this. My goal would be is that by July 1, if we could have around 125 pharmacies around the state doing this testing. So basically, I think if we can help alleviate a lot of the issues, if we have at least one pharmacy in each of the 102 counties, that's a start. I'd like to have a hell of a lot more, but I think we have to start with the goal of having at least one pharmacy in each county doing the testing.
And you can do that.
Yeah, I think we can. And like I said, it's going to be very difficult.
That's my statement. I think you can do that. That's not overreach. That's absolutely possible.
Right. And as we've talked about a little bit, we've talked about the board of directors. It's, you know, the association is willing to put our, I guess, our nostrils where our mouths are. I guess, I don't know, I'm not sure how to put that. We're actually looking at that we will be engaging in some of this testing as well. That we're going to help have some feet on the ground with myself and Starlin to start with, to help with providing some of this testing here in Springfield. So once we get this up and running, because as we said, the association is a CLIA-waived laboratory. It has been for over 15, almost 18 years. And this is an opportunity for us to be able to demonstrate that pharmacists individually without a pharmacy can provide these services safely and effectively and competently.
Well, I just
Scott, go ahead, Gary.
No, you better mute me again pretty quick or I'll keep talking.
You're
I just
good.
want to say, you know, just to support you guys, if you ever sit back and say, do you think, you know, do we really have the number of people out there to do that? And I think you do. I think from questions I'm hearing, conversations that I talk to people about, they're anxious to try to help. And we all say the same thing. We're not going to do it for nothing. But there are people out there, yeah, around my neck of the woods for sure. But I'm talking about other people I just talked to that even aren't really that active and say, yeah, but that's something I would come back and help do. So I want that to be motivational to get things moving forward as much as you can, which I know is a slog in a process, but if you ever like, gee, I don't even wonder if we get through all this, if we'll even have people that want to do it, I think you will.
I absolutely agree. And I think one thing to also think about, this also goes beyond just testing for or administering the COVID test. It also looks at, you know, we could be doing telehealth or in-person appointments to screen patients to write prescriptions for the antibody test as well. So there's a lot of opportunities here. Sorry, I didn't know if you wanted to add anything on what I stated here.
Now, I've been trying to pull all the links together. I sent you an email and I copied some people on it so you can read it. The thing is that if they want us to step up and do it voluntarily. I know that Walgreens and CVS and Rite Aid and Walmart got block grants. And so that they may not be doing, and that's how they're getting paid. And the Illinois Walgreens got a Illinois block grant, but considering their headquarters is in Chicago and Chicago was hurting, I think that was right for them to step up and do that. I know Lewis was, within 48 hours, he was up and trained and was standing in line. So the donning and there's 2 stages. You need to know how to, huh?
Doffing.
Dossing. So there are, you have to learn how to do that, and you have to witness, someone has to witness you robing and disrobing on everything before you can even start doing any of the other. So that's step 1 in training. And then the second is depending on there's several of the tests out there now. I just sent Garth from this morning, the infectious disease group put together a set of guidelines and step-by-step processes, and they're going to have some videos. The pharmacoepidemiologists the organization has for free until July all their online training on how to proceed with all this. But it really does take a process for everybody to get together. Now, I heard today that IPHA just now, just like Garth had to go through and get Amazon to acknowledge that we were a healthcare provider, IPHA just now got enough supplies to even have Dan and his educational crew design the training programs that they could send out to us as pharmacists so that we can start training for it, so that even to train the trainers. So several people in our organization have signed up to be train the trainers, and Dan just now got PPE enough and the swabs and the testing materials so that they could even make the videos and go through and create the step price. They have all the didactic stuff is finished. It's putting all the wheels in motion and being able to send kits out so that each group can have a train the trainer. That makes sense. But
Yes, it does.
the problem hasn't been, we didn't have swabs, and then we didn't have the liquid that goes in the bottom of the tubes, but then you didn't have it was all these parts. What we're trying to do is not get involved in that process, but hopefully get an Abbott or a Roche CLIA product so that would prevent us from having all these other moving wheels. But irregardless, if they're going to train you, they're going to train you to use whatever testing process gets sent to you at the time. So we may get one set of tests at one point in time, and then when the other one comes up, they'll get that one. So what they're wanting to do is cross-train everybody on all the processes and procedures. So the donning and doffing happens no matter what. The other thing that came up is that the antigen tests might be a self-test.
Right.
So, and that FDA just approved the first one in there. And the infectious disease docs are keeping a list of the fakes along with FDA, but that's a nice place for you guys to go look. Garth, I sent that so you can include that in your email thing that goes out. And what else was I going to say? Now I lost it. Oh, by the way, Gary, this year at the annual meeting, if we get to have it live, you can't kiss any babies. No kissing
there was
babies.
a question earlier about quickly going off testing, and then we'll come back to a couple of questions. Did the state allow any former technician licenses to be reinstated like they did with nursing? No, at this time, the department has decided for pharmacy not to allow retired or inactive technicians or pharmacists to come back or be reinstated. They did allow out-of-state pharmacists in good standing to be able to assist, but not any inactive or retires at this point. There's a question, will the testing be processed in the pharmacy or shipped at the lab for a test? I think Starlin just kind of covered that with some, depending on what we can get. Some we can do with rapid tests in the pharmacy, some would have to be shipped off. Do we know the cost of the PPE for the testing? No, that's kind of what we're going through right now, because I'm trying to find something that's a consistent supplier for us, so we're not just in a constant search for supplies.
Aren't from
But
China.
really good questions, folks. Do what, Charlotte?
That aren't from China.
Ah, yes. What other great discussion, everyone. I'm really glad that we dived into this. I was kind of wondering if this was going to be a shorter town hall for us, but what other questions, comments, concerns that you guys have?
The most reliable antibody test is a serology test, and so that would require you to have phlebotomy skills, which is in residency I did all my own pharmacokinetic draws. So if we had butterflies, but that's a whole nother setup, and that's not CLIA-waived. So, but there are some testing stations that are owned by hospitals that are having that happen in parking lots. But that's not what we would want. That's not what we're striving to do. So Gary, I have a question for Gary. So you're saying Memorial Medical Center sponsored Walgreens in Central Illinois?
No. What I said was we were looking for a place at Culbertson to do 24-hour, to guarantee 24-hour turnaround.
Right.
And Memorial, we went to Memorial, they said they couldn't do it, and they went, and LabCorp couldn't do it, and so they said they were using Walgreens, because Memorial said, we're using Walgreens because we can get 24-hour turnaround.
Because they have a deal with Quest.
Yeah, so that was shocked that was a Memorial's best option, was going to Walgreens.
That is shocking.
And that's, so, but they need the 24-hour turnaround because we're going to start doing elective surgeries again. So we got to know, right away. And that's what we're struggling with in Rushville, to find somebody who will guarantee that we can do that, because we can't come in and test them and then not be sure how quickly we're going to get the results.
Right. So what do you use? What do you use now?
Well, I don't know yet what we're going to do, but because we haven't started yet, but right now it looks like we might be able to work something out with Blessing, go in the other direction. So
have you talked to your county public health department?
They're involved. They just can't guarantee 24 hours.
Okay.
Yeah.
Yeah, that's the problem with the state labs right now. They can't guarantee less than 24-hour turnaround. They're doing good if it's 72 hours turnaround.
Yeah. So we may have worked that out. It's not a large volume of patients for us, but it seems like if testing is going to be going on, if we were set up to do it and could make it work, obviously we're 2 blocks away. We could do that. All pharmacies that are in our communities that are close to small hospitals, that would work great. I just saw it as an opportunity, but I know it's more complicated than that.
We're going to be busy, folks, in the next 8 to 10, 12 weeks. So we appreciate all of you jumping on board and volunteering to help. So thank you.
Gary, let me find out where Springfield Clinic's doing theirs. They may be doing it through Memorial to Walgreens, but I'll ask. I'll text you later.
Thank you.
He's asleep right now. He had a full day of surgery. Today was his first full day of surgery for 60 days.
I hope he didn't have to wear a mask all day.
He wore 2 masks.
Any other questions or comments?
I think we should get masks with IPHA on the front.
Oh my goodness. We had a comment about NYU study reporting 50% false negative with the Abbott rapid test.
Yep.
And I know Abbott is taking a look at that. Mm-hmm. They're continuing to try to address this, and I think address some of the methodology in that study as well. But even though they're addressing it, they're also releasing additional COVID-19 related testing products. So But well, hopefully they can get that on board because, you know, they were one of the first ones onto the scene, and a lot of times the first one on the scene is the one that gets the most scrutiny. So.
Well, and there was a question about the sample sizes and the sample
Right.
processes. So they're narrowing down whether it was a deep and that or not enough, or so when you do, has anybody done a nasal pharynx swab? Had one done to them? I mean, I have.
I have. It's an interesting experience.
It's
And
not
the best way I could try to explain it to someone is that weird feeling in your nose when you're in a pool and you get a bunch of water up your nose the wrong way. That kind of eerie, weird feeling is kind of probably the best way I can kind of explain it. And it's still not the best it's not the best description.
Well, and if you have a deviated septum, it's there. You feel a lot of pressure, so you
Right.
you have a sinus pressure. You want to expel, which is why the person giving you the test needs to be have the plastic all the way. A whole facial plastic is that's what Lewis and those guys were showing in their pictures.
Right.
And that's what is recommended, because they will either, if you have a gag reflex, they will either vomit, sneeze, or cough on you through the process. I mean, I saw a demo on the epidemiology webpage where they were having people self do the nasal cannula. So the problem is people get halfway there and then they don't want to do it anymore. So you've got to, yeah. So they want to back out. If I were getting it done again, I would want to do myself, but I know that I need to go back to where I can feel it on my tonsils. So patients don't necessarily want to do that. It would be nice to get Lewis on here. I tried to see if he could. I reached to have him give us news on the streets. what the experience.
Well, hopefully he can join us in another time, because I know he's been on here in the past.
Yeah.
Well, we've got at least 10 minutes scheduled left for everyone. Does anyone else have any comments or questions? Jenny, I see that you're unmuted.
Well, I was just going to say, whenever I was reading through the point of care Abbott test, it had listed that just regular nasal swab as well as a throat swab could also be used for the specimen. So I wonder if there's anything to different methods that people have been using since it launched, and if that's feeding into some of the discrepancy in accuracy.
That could be. Oops, Starlin, you're muted.
Sure, I
There you
forgot.
go.
That's what the infectious disease review was. That's what they and so that what they were going to do is, some people are doing what they think people are and retesting that, but it had to do with the amount, the amount of sample size, the amount of stuff, mucus. They needed a good mucus plug to get it in there. It's kind of like have you ever done an upper respiratory sample? Anybody do COPD and asthma? So you got to work up a good one for a sputum sample. And I'm wondering if dry noses, if that interferes with it too, depending, the climate. If you go out to the infectious disease website, you can see all the theories that are out there. But you've got to nail all those, because you've got 100 million people all delivering this, supposedly the same, but not necessarily the same. They just have to see which false negatives were associated with which behavior.
Any other questions or comments? All right. Well, I don't see any other questions or comments. We'll let you guys get off a couple minutes early tonight. And we'll join everyone again next week and same time, 7 o'clock. And I really appreciate everyone for joining tonight and engaging in this very fruitful discussion. Thank you, everyone, and we'll see you next week.